I'm thinking about Nav Sidhu's paper about trainees and who gets the block. And there was a big gender bias in folk that got the block. And male trainees got heaps of blocks, and female identifying trainees got not many blocks. And that was also for other procedures as well. You can explore the reasons around that. So we sort of thought, oh, it's a trainee issue, that we're not delivering equitable training to everyone who comes through the unit with us. But that does extend to consultants also. And it's a self-perpetuating thing, because in the department, and every department has probably the handful of folk who are guns at the blocks.
Yeah.
So everyone goes, oh, Bugger Lugs is there in Theatre 4 today. Let's go ask them to go do the block.
Let's go and ask Steve-O. Steve-O, can you do the block, eh?
yeah. But I think it's almost analogous to the conversation about awake fibre optic intubation, about how many, with the advent of video laryngoscope, the numbers of awake fibre optics are not very many. And I know some have had conversations and saying, well, it's unrealistic to have every working anaesthetist really be able to know how to do those not very common, tricky airways.
So hold on, I'm gonna stop you there, because this is really, really interesting, because Jeff and I had a conversation about this not so long ago, and also there's been a bit of chat on Twitter recently about a little teaser that Jeff promoted about awake head and neck blocks for awake tracheal intubation. Now, I work in a centre where there are some worldwide experts at awake tracheal intubation, right? And everyone knows that. But the problem, exactly in the same way with regional anaesthesia that's been created, is the expectation is if somebody needs to have an awake tracheal intubation, you have to call one of them to do it. Whereas actually, is that true? Surely this should be a skill that is core, same way as regional anaesthesia.